Good afternoon. Today we'll be dealing with abnormalities of puerperium. You already had a class on normal puerperium and on third stage complications. So going forward from there, today we'll be dealing with the abnormalities encountered during puerperium. So puerperium is a time of great importance for both the mother and her baby. Usually we don't give much importance to the puerperium. However, we can encounter several problems during this period. Hence, we have to emphasize certain things about puerperium. The problems which can be encountered during puerperiums are diverse. Of them, the important ones are secondary postpartum hemorrhage, puerperal pyrexia, puerperal sepsis, problems of the breast, problems of the venous system, problems of urinary tract, chest. There can be problems, psychological problems, and other problems of the genital tract. So the most important problem encountered during puerperium is puerperal pyrexia. The definition of puerperal pyrexia, which is very important from the examination point of view, is a rise of temperature reaching 100 degrees Fahrenheit, that is 38 degrees centigrade or more, measured orally on two separate occasions, 24 hours apart, excluding the first 24 hours and within the first 10 days following delivery. Since the criteria for definition is quite important, I'll repeat again. Puerperal pyrexia is a rise of temperature reaching 100 degrees Fahrenheit, that is 38 degrees centigrade or more, measured orally on two separate occasions, which is 24 hours apart, excluding the first 24 hours, within the first 10 days following delivery. What can be the causes of puerperal pyrexia? They include puerperal sepsis, which is the most important cause of puerperal pyrexia, and other causes include urinary tract infection, breast problems like breast engorgement, mastitis, and breast abscess, infections of the cesarean section, wound or perineal wound, or even if there are vaginal lacerations. Pulmonary infection can also be cause of puerperal pyrexia. There can be recrudescence of malaria or pulmonary tuberculosis, usually because of the decrease in the immunity during puerperal time. Meningeal infections can also rarely be there. So now coming to the most important cause of puerperal pyrexia, that is puerperal sepsis. How is puerperal sepsis defined? It is an infection of the genital tract which occurs as a complication of delivery and it is termed as puerperal sepsis. As compared to the olden days, nowadays there is a marked decline in cases of puerperal sepsis because of the improved obstetrical care worldwide, including developing countries like ours, and there is availability of wider range of antibiotics, so infection is cured in time. There are certain risk factors which account for puerperal sepsis. They include malnutrition and anemia. There can be impaired immunity. Diabetes is one of the important causes of puerperal sepsis. Then obesity, vaginal infection or pelvic infection contracted during antepartum period also can lead to puerperal sepsis. Then premature rupture of membranes of more than 18 hours duration, and group A, streptococcal infection. What are the risk factors during the intrapartum period? They include invasive procedures like low segment cesarean section, operative vaginal delivery, and or traumatic vaginal delivery, prolonged labor, obstructed labor, repeated vaginal examination during the first stage of labor and even sometimes during second stage of labor also. If there are retained placental tissue or membrane in the uterine cavity, and hemorrhage is also one of the important causes of puerperal sepsis. So what is the mode of infection causing puerperal sepsis? It is usually a wound infection. The various sources of infection, that is the various sources of organisms from which it can be caused, It can be endogenous, where the organisms are already present in the genital tract before delivery, the example being anaerobic streptococcus. Or it may be an autogenous, where the organism present elsewhere in the body like skin or throat migrate to the genital organs by bloodstream or by patient herself. The examples include beta hemolytic streptococcus, Streptococcus per se, then Escherichia coli and Staphylococcus. Or it can be an exogenous spread, that is infection where infection is contracted from sources outside the patient, for example beta hemolytic streptococcus, again Staphylococcus and Escherichia coli. The causative organisms for puerperal sepsis include mostly the Dorvalens bacilli. When the immunity is decreased, then this itself can cause infection. Yeasts like Candida albicans, which accounts for approximately 25%. Then certain gram-positive organisms like Staphylococcus albus or aureus, Streptococci. Then gram-negative organisms like Escherichia coli. Then anaerobic organisms like Clostridium welchii, Clostridium septicum. And certain mycoplasma and chlamydia, Neisseria gonorrhoeae are the rare causes of puerperal sepsis. MRSA is one of the rare but virulent cause of puerperal sepsis. So, how this pathogenic factor is responsible for puerperal infection? The cervicovaginal mucous membrane is damaged even in normal delivery and in the uterine surface also, especially when at the placental site. So when during the third stage of labor, when the placenta separates from the uterus, then the blood clots present at the placental site remain there only, and they are the excellent media for growth of the bacteria, and if they are not evacuated, then it becomes one of the nidus for infection, resulting in puerperal infection and puerperal sepsis. So, what are the primary sites of infection for puerperal sepsis? They include all the genital organs like perineum, vagina, cervix, and then uterus. In the perineum, there can be lacerations which are likely to be infected. The wound edges of these lacerations become red and swollen, and there may be collection of the purulent discharge resulting in the complete disruption of the wound. That's how usually during this, if there is a second degree or third degree or fourth degree of perineal tear, they are more liable for infection as compared to the episiotomy. Then vaginal lacerations can be infected directly or by an extension from the perineal infection. Here also the mucosa is swollen and hyperemic, resulting in necrosis and sloughing. The cervical laceration also can become the site of infection. Usually they are ignored because during delivery the cervix remains inside, and sometimes we may miss the cervical lacerations. But in minor degrees of cervical laceration, it doesn't cause infection. But if there is a major degree of cervical laceration along with the vaginal and perineal laceration, it can be a nidus for infection. So the clinical features of the local infection, that is in the perineum, vagina or cervix, are usually mild. In this one there is a slight rise in temperature. There can be generalized malaise or headache. And then there is a redness and swelling of the local wound, or in the extreme cases there can be pus formation and disruption of the wound, and the temperature sometimes may be quite high. So if there is uterine infection, which usually can be more severe than the local infections described earlier, in this the uterine infection can be in form of endometritis, endomyometritis or endoparametritis. It can be either mild or severe uterine infection. The rise in the temperature is usually more than 100.4 degrees Fahrenheit, and pulse rate is usually more than 90 beats per minute. There can be an offensive and copious lochial discharge, and uterus is usually subinvoluted, and on palpation it is tender. If it is not controlled at this stage, or if it is a severe infection, it can be a severe uterine infection. Severe uterine infection onset is usually acute with very high rise of temperature, which is often associated with chills and rigors. The pulse is rapid and it is out of proportion to temperature. It may be more than 100 per minute or more than 120 per minute also sometimes. Often it is associated with breathlessness, cough, abdominal pain and dysuria. As compared to the mild infection, lochia may be scanty and colorless. When we had seen in the mild uterine infection, it is copious and false smelling. And uterus here also may be subinvoluted, and here also it is tender and softer as compared to the one in which there is no uterine infection. And there may be associated wound infection of the perineum, vagina and cervix. That means the whole of the genital tract from the perineum till the uterus is infected. If the infection is not controlled at the uterine stage, it can spread to the extrauterine places. And usually this is clinically evident by pelvic tenderness, which indicates usually pelvic peritonitis, tenderness in the fornix that indicates parametritis, and or there may be bulging fluctuant mass in the pouch of Douglas that indicates pelvic abscess. So extrauterine spread can be to the tubes, and usually to the tubes it is a lymphatic spread. It's an infection of the fallopian tubes and ovaries, and ultimately it will form tubo-ovarian abscess if it is not controlled at the initial stage. There can be parametritis, which is a tenderness on either side of the hypogastrium. There is a unilateral indurated tender mass, and a rectal examination, if you do it, confirms the diagnosis of parametritis. In cases of parametritis, usually there is a sustained rise of temperature after 7th to 10th day during puerperium. So another extrauterine spread can be in form of pelvic cellulitis. It can be either in the lymphatic spread or a hematogenous spread. And this, there is an exudation or formation of indurated mass, which is usually confined to the one side of the uterus. It can manifest also in form of pelvic peritonitis. There is a localized pelvic abscess. There is a pyrexia with increase in the pulse rate, which may be quite high. There is a lower abdominal pain and tenderness. And sometimes the guarding may be absent, and bulging fluctuant mass can be felt through the posterior fornix. And on cervical movement also there is tenderness, and there is a swinging temperature. It can be very high, and it can also present in form of diarrhea. If it is much more virulent then and is not controlled at this stage, it can lead to general peritonitis with a very high degree fever with rapid pulse. There can be vomiting, diarrhea, generalized pain, and patient looks very ill and moribund. Thrombophlebitis is another form of spread, extrauterine spread of infection, and clinical features are usually similar to the uterine infection or parametritis. This again swinging temperature continued for a longer time with chills and rigors. Features of pyremia can be present according to the organs involved. And septicemia, and in cases of thrombophlebitis, it can be in the ovarian vein, which is usually involved on one side. There can be uterine vein involvement also, and suppuration and embolism to other organs can also occur in thrombophlebitis. Septicemia is the ultimate stage where there is a high rise of temperature, usually associated with rigor. Pulse rate is rapid, and blood culture is positive. Symptoms and signs of metastatic infection can be seen in lungs, meninges or joints, so leading to endocarditis, pericarditis, renal abscess, lung abscess. There can be meningitis and arthritis. So how do we approach a case of puerperal pyrexia? And the underlying principle of uh, the approach to case of puerperal pyrexia include: one is the locate the site of infection, to identify the organism by doing culture, and to assess the severity of the disease, depending upon which the management can be programmed. So usually case of puerperal pyrexia is considered to be due to genital sepsis, that is puerperal sepsis, unless proved otherwise. History is very important in these cases. Antenatal history of any infection, of any risk factor, the intranatal history of the type of delivery, the mode of delivery, and whether the aseptic precautions can be taken or not, and postnatal history, of course, is important. Clinical examination include general, systemic, abdominal examination, and pelvic examination. So we should see if there is any tachycardia, any fever, or any systemic involvement of infection, if there is any subinvolution or clinical features of local infections of the perineum, vagina, or the uterus. The investigations include high vaginal and endocervical swab for both aerobic and anaerobic culture, including antibiotic sensitivity test. The urine routine examination and urine culture should emphasize upon the midstream collection of the urine. And a complete blood count, including malarial parasite, is important to see whether there is a bacterial infection. If there is a low platelet count, which may indicate septicemia or DIC. Blood culture may not be required in the initial stages, but however, if it is a high-grade fever with chills and rigors, one should do blood culture. Ultrasound, usually to detect any RPOC within the uterus, to localize any pelvic abscess, and sometimes to collect sample from the pelvis of pus or fluid for culture and antibiotic sensitivity, and for color flow Doppler study to detect any venous thrombosis. Use of CT and MRI is, in most of the cases, it's not required, but in very few cases may be required when the diagnosis is in doubt or there is doubt of pelvic vein thrombosis. X-ray chest PA view to be taken in cases of suspected pulmonary tuberculosis, and also if we suspect any lung pathology based on clinical examination. Blood urea and electrolytes, it to be done in very selected cases. If where we suspect, then there can be renal failure if the disease progresses, or if the laparotomy is required. In those cases, blood urea and electrolytes may be required, is not required routinely. So prophylaxis, of course, is very important. It can be in antenatal, intranatal, or postpartum prophylaxis. Of course, if you see the risk factors of puerperal sepsis, which includes the nutritional status. So improvement of the nutritional status is an important measure of prophylaxis, especially the anemia should be corrected, and if there is any septic focus in the body during the antenatal period, it should be eradicated by administration of proper antibiotics. In the intranatal period, of course, surgical asepsis to be maintained during delivery, especially during the operative vaginal delivery. And the screening for group B streptococcus in a high-risk patient. However, there is no need of prophylactic antibiotics if there is a suspicion, unless it is proved, then unless it's proved. So in operative delivery, especially during cesarean section, prophylactic use of antibiotics is important. And during postpartum period also, aseptic precautions usually to be continued for about 1 week. It's the period usually when the open wounds on the uterus and perineum and vagina are healed. And of course, we have to take care of the abdominal wound in cases of lower segment cesarean section. Restriction of visitors is very important. Otherwise, the more the visitors, the more chances of infection. Sterilized sanitary napkins should be used. And infected mothers and babies should be in isolation. so that other patients and babies do not contract infection. So what's the treatment for puerperal pyrexia? Isolation of patient in some cases where it is severe, and then adequate fluid and calorie intake is important. Correction of anemia, if it is severe degree of anemia, sometimes blood transfusion also may have to be given. Indwelling catheter not required in most of the cases, but if there is suspicion of severe infection, then indwelling catheter, Foley's catheter to be put. Monitoring of pulse, respiration, temperature is important, and of course the local discharge. Intake output chart important in post-cesarean cases and in severe cases of puerperal sepsis. Antibiotics, if it is a local infection, usually oral antibiotics in form of cephalosporins will do. And in the case of severe infection, first of all, we should collect the culture from the sites where it is infected and to send it for culture and sensitivity report. Pending that, one can start gentamicin. Usually in severe infection, the loading dose is 2 grams per kg body weight, repeated at 1.5 grams, 1.5 milligram per kg, 8 hourly. Clindamycin and 900 milligram 8 hourly, and metronidazole 500 milligram 8 hourly, IV 8 hourly. So all these should be given in parenteral form. And in much more severe sepsis, combination of either piperacillin tazobactam or carbapenem can be added with the clindamycin. In cases of methicillin-resistant Staphylococcus aureus infection, it should be treated either with vancomycin or teicoplanin. Surgical treatment in form of major surgery has got a very little role unless there is a extensive tubo-ovarian abscess. Minor site infections like episiotomy or perineal wound infection can be treated. Initially the wound should be opened, and thereafter we can do secondary suturing. Same applies to the abdominal wound after following cesarean section. Usually if the wound is infected, initially secondary suturing should not be done. Once that infection is controlled, later on we can do secondary suturing.